Okay, great. All right, so welcome everybody, and thank you for joining us again. This is our third session of our Learning Collaborative on enhancing the use of clinical preventive services for older adults. This is presented to you by the National Center for Health and Public Housing. Before we continue, I know we may have some participants that are probably joining us for the first time, and that's completely fine. So the mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. And the content of this learning collaborative is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the US government. We have the message from Rebecca. That's fine, Rebecca. It's okay. All right. And then with us today, we have Dr. Kevin Lombardi, who is the Manager of Policy and Health Promotions. We also have with us our Health Communications Analyst, Olajumoke Oladipo, and myself, Filipina Sandoval. I am the TTA Manager here at NCHPH, and we're all going to collaborate and work together to help provide you guys a very interactive session today. This reminder that entry that please make sure that you engage in the chat. This session is meant to be very engaging and interactive, so we encourage all of you to not just participate in the chat, but also unmute your line whenever we go through some of the questions, and participate verbally as well. This meeting is also being recorded. The slides and recording link will be sent to you all via email after today's session. All right, so with Dr. Kevin Lombardi to get started.
Hi, everyone. Welcome back. And I will say, join when you can. This is not a attendance requirement. We want you guys to be here where you can and enjoy it when you can. It's a conversation. If you can't catch it, check the recordings out. They are entertaining, fun to watch, and bring the conversation back to your colleagues and to your organization. Today, we're going to keep following Mrs. Tiller. We met Mrs. Tiller in session 1. She's an older adult living in public housing with a number of chronic diseases. To name a few, she's type 2 diabetes. She's physically disabled and unable to walk without a cane, now a walker. She has hypertension and is often unable to take her medications. She's unable to take them because there's so many. 23. This is not unusual, folks. I've seen some medication lists that are like sort of the Looney Tunes scrolls that just go down like a carpet. Patients take a lot of medications, and when they have multiple chronic diseases, it is not unusual to see patients taking 20 medications. Well, this is the case of Mrs. Tiller, and because of the complexity of her medical conditions, she has to take that much. And we found in our second visit, a home visit, that Mrs. Tiller had a medication reconciliation mess. She also lived in an apartment that had a number of safety issues: carpets, hard lips between surfaces. Her bathroom, even though she was walker dependent, did not have any disability features at all. For a patient like that, that is an accident waiting to happen. We discussed those preventative measures that we can take as people in the field, seeing patients in various different ways to maximize that safety and make sure the appropriate interventions get to the patient. So today we're following Mrs. Tiller to the next step of her medical history, which is an injury. When you follow these patients long enough, you'll know that this particular injury we're going to talk about today, it shows up a lot. So no spoilers. We'll get into things in a moment. Fide and Jamoke, can you wave to the crowd? Yeah, there they are. Um, we are going to start, the three of us, Kevin, Fide, and Jamoke, are the core of our interdisciplinary team. As you know, I'm a physician and epidemiologist, and I'm going to be serving as the attending physician reviewing Mrs. Tiller's care. Uh, Fide is going to be our patient education expert, and we're going to talk about how we can make sure the patient can understand the preventative steps we need to take. Jamoke is going to be our health analyst and is going to discuss the pathophysiology and the nature of these injuries and how they impact Mrs. Tiller with us. And all of you, I'd ask you to put the hat on that you wear and be that member of our interdisciplinary team as well, because this patient is going to have a number of challenges that are a reflection of the daily things that challenge these patients and act as risks for serious injuries, serious causes of morbidity and mortality. Next slide, please. And they know the system. If we could go to the first slide of the case study, please. Okay. So this is a little bit from last time. Mrs. Tiller was referred to her health center's social services department. A CHW visited her at home. Next slide. When at home, we discussed Mrs. Tiller's medication reconciliation. So, Fide, did we get this far at the last session?
Yes, I think this was when we started talking about some of like the social um aspects of her condition.
Oh, yes. And the challenges of Mrs.
Yeah.
Tiller managing chronic diseases, for the effect on her mental status, and the complexity of her medications, of course. Next slide, please. We intervened with Mrs. Tiller to make sure that and next slide after that, a family member was seeing her once a week, and that and that her medication was being checked as well. Next slide. Now, let's take a close look at her home safety check again, because this is not unusual, in particular for residents of public housing, of which Mrs. Tiller is one. Uh, Even for a patient who is not aware of the safety issues in their apartment, there is a risk. When a patient is aware of the safety issues and is scared of falling, there is an additional risk as well. And this is the case of Mrs. Tiller. She noted that she felt unsafe at home. And if you take a look, you can see why. This patient is walker dependent. She lives in a one-bedroom apartment by herself. So she's taking care of her daily needs. She's visited by neighbors occasionally. And she has a nutritional deficiency in anemia, vitamin D deficiency, and so forth. And when you take a look at her kitchen, it's pretty clear why. No fruits or vegetables. She is the archetype that in the emergency room is often called the tea and toast person. It's typically an older adult who has their tea and toast every day and otherwise doesn't eat any nutritionally dense food. Next slide, please. And some more detail on that. What we see is overall an apartment with a number of issues with regards to fall risks, trip risks, and our CHW intervenes where appropriate. Next slide, please. And next after that. So, Mrs. Tiller's CHW ranges for a host of services, and I just want to go through these one by one. One, Meals on Wheels to provide meals Monday through Friday Typically, Meals on Wheels will do that, but they'll also have sometimes optional things on the weekends and emergency meal kits. It differs from place to place, but that service was networked to Mrs. Tiller. That helps both with nutrition and social isolation because the people are very friendly and they form relationships over time. Uh, the CHW corrects the hazards while in the home. She's able to move the carpet to get rid of some of them and to arrange, and there were some electrical cords and so forth. The CHW took a conservative approach and removed everything that was a risk for Mrs. Tiller. She also arranged for some supplies for the bathroom so that Mrs. Tiller had a reduced fall risk in the bathroom. Not an eliminated fall risk, a reduced fall risk. And there was social collateral done with Mrs. Tiller's daughter so that she is now going to be visiting the patient once a week and helping to arrange her medications. Now, if we remember, Mrs. Tiller has hypertension, and her exacerbations, we determined, were linked to poor medication compliance. Giving her that connection to her daughter and ensuring that that happens allows Mrs. Tiller to have her hypertension and her other conditions under control. And that's going to have an effect on her mental status. That's going to have an effect on her fall risk and her risk of injury. Next slide, please. And just to go over some, there's some really cool products here. You can find pill holders that are timed, that have alarms. You can find 30-day products, week products, and 2-week products. I did some look at some of the widely available ones with some recommendations for patients. And the alterations in the different types of textures, the different colors, and so forth, are important for patients with different sensory disabilities and so forth. Different products are going to be more appealing or less appealing for them. So know your patient, look at the products, and help and have them choose what works for them. Here's some to take a look at. I put links on as well. There's some cute ones. You can really have fun with this if you want to. The ones on the left kind of look like Pokeballs. I'm looking forward to sending these to some of my colleagues who I think will have fun connecting to the patients. Next slide, please. Okay, so here we start today with Mrs. Tiller's next step in her medical history. 2 weeks after Mrs. Tiller's home visit, her primary care provider receives notification from a physician at your local hospital's emergency department. She provides the following updates. Mrs. Tiller was seen at the AED after she experienced a fall in her home. The fall occurred in her bathtub where she slipped, bumping her head and landing on her left hip. Diagnosis was an intertrochanteric hip fracture with internal rotation. She did not lose consciousness. Her mental status was markedly reduced, and she exhibited extreme confusion and agitation in the emergency room. Now, I'd like us to take a moment. This is all we know. We've been following this patient for 3 weeks now. Pop your thoughts in the comment, raise your hands, and join the conversation. What is coming to mind for you when you see this patient? When you see this update about Mrs. Tiller? What comes to mind? We have some very interesting and very valuable collateral here. So I'll throw it to you for the hands and comments, Fide, and I'm standing by.
Yeah, for sure. Again, just a reminder that you are more than welcome to unmute your line and just chime in and provide us with your feedback. Okay. Do we have any volunteers that would like to let us know what is standing out to you so far?
Hi, it's Benvinda. I have So when the CHW was assessing Mrs. Tiller's apartment, her home, did she maybe assess the bathtub to see if there was maybe like a rug there to prevent her from slipping? Um, and was any referral sent to maybe VNA, someone to go in and assess her for maybe a personal care attendant or home health aide that can go there daily? Because it doesn't seem like the CHW is able to visit the patient, weekly. So maybe the patient needed more assistance as far as someone there with her.
I think you're right on. 100%. So, if I may reflect on some things that you mentioned here, and add some context. One, there was an assessment of the bathroom, and there were arrangements made for the supplies. We're viewing it from the primary care perspective, and we do not know if those were actually installed or not. So it may have been installed, it may not have. Even if it was installed, this is a patient with a mobility disability, and there is still a significant risk. And the other thing, as you correctly identified, this patient still is at home by themselves all day, with the exception of an occasional visit. Resources such as a home health aide or a visiting nurse are exactly what this patient needed and they did not get. And as you've also correctly identified, this patient fell. She was a fall risk. A home health aide would have been the perfect support for her to prevent that fall risk. We might not have had that if that arrangement had been made. Thank you very. Could you tell us? Could you give us another intro and tell us who you served and how you served them, please?
Oh, sure. So I'm a certified community health worker. I work for WellSense Health Plan. We are a managed care and accountable care organization in Massachusetts. We offer care management and a lot of support services to our members from 1 month to whatever age. There's no age limit as long as they have Medicaid or Medicare or subsidized health plan through our health connector.
And
So
I will say, no, please go.
no, I'm just going on and on, but
No, I'm
basically our
from your neighborhood, and I think there's
Mhm,
actually some interesting things to bring up there.
mhm.
I'm from Middlesex County. I lived in Massachusetts until about 10 years ago,
Oh, okay.
and I practiced as a paramedic in the Lowell area for 10 years. Massachusetts has been an innovator in elder health for a very long time. And there's many more supports in Massachusetts than other parts of the country. So I'm interested to hear, because I know in general sort of a regional area of
hmm
expertise. Are you seeing patients like Mrs. Tiller who have these issues? And
Yes.
is there any insight you can give us into what their lives are like?
Well, oftentimes, as noted here in this case, oftentimes they're alone, they don't have a lot of support. And that's where we, as a health plan, that's where we would incorporate long-term support services for someone with this scenario as Mrs. Tiller, um, ensuring that she has the support she needs, whether it's Meals on Wheels or medically tailored meals, where she has some issues with high blood pressure and looks like I think she might have had type 2, helping to support, with transportation or maybe a community support person that can help bring her to her appointments and so forth. So we collaborate a lot with community partners, including elder services, behavioral health services, community partners, and so forth. So
I
we
love
we
that.
treat
I
them as
love
a
that.
whole from holistically the whole patient care. So we try to use a team of community health workers incorporated with social workers and nurse care managers. So that way all her medical and psychosocial needs would be met. And I think our model of care um, has been mirrored in other states. But we, we definitely were one of the first to incorporate and look at the members or patients as a whole and addressing all their needs
Mm.
because
I will
everything
say,
ties.
no,
Sorry.
I will say there are a lot of resources available in your area, and what I can see is that allows you to take a very tailored approach to patient care, and that has real benefits. Also note that you work for a health plan, and
Yes.
that makes me kind of think of an important thing, which is the return on investment of CHWs. CHWs really do pull their weight for the health system and reduce costs. And
Yes.
the fact that for a number of years, health plans have been investing in growing their presence with CHWs in communities they serve shows that there is both not just a patient care advantage to this, but a huge public health resource burden management issue as well. It makes taking care of patients much more efficient and much less
Absolutely.
costly, much less costly.
I look at it as a CHW. I'm the bridge, right, between the patients and the care and the providers. So I'm that bridge that will connect all the services the patient and the providers, whether it's a community partner, elder service, primary care doctor. I'm the bridge that connects the member to all the services that they need. So CHW work is so important. And it looks like a lot of other health plans throughout the country is looking at hiring more CHWs and having more trainings for CHWs. I was lucky enough, I did a training with the Public Health Commission many years ago. I've been a CHW now for 20 years. But I was just recently, Massachusetts, they're one of the states that do recognize CHW as a licensed profession. So I'm also licensed with the state, with the Board of Health, with the
Mm.
state licensure. And that only came about in 2000, let's see, 2000, I want to say 16 is when I was able to get my CHW license. It was a lot of work to get there. There was a lot of MACHA, which is Mass Community Health Workers Association. They did a lot of work with the State House to, and advocate for CHWs to get their license and make it the profession it is now. It's
Well, what I will say is, um, one, a lot of I keep a close eye on what happens in your region because a lot of
hmm
state law innovations happen in Massachusetts, and you'll see things percolate from Massachusetts to different states, and then often to the federal level. So it's a good
hmm
way to see where things may be going on the health front.
hmm
And what I will say is, I know for a fact that there are places all over the country that are working with state legislatures to push that forward in your type of model. And what I'll also say is, it helps patients. So good for you, and thank you so much. Good for you and your community, actually, and thank you for sharing that.
Thank you.
Um, Mrs. Tiller, let's go back into her injury and kind of take a step. Oh, I'll ask one more thing. Um, Fide, your thoughts on Mrs. Tiller? There's a lot to pull out here that we really need to expose, and I'm wondering if you have any thoughts about what came to mind first for you when you considered this recent injury.
Yeah, well, one of the things that Benvinda mentioned, and I think she was like right in line with what I was thinking, is about her experience of falling in her home. So, I can just assume that she didn't have the proper um things needed in her home for her to have a safer environment overall. And then also, just like, like the issue with the bathtub. And then also her diagnosis of the intertrochanteric hip
Yeah,
fracture with internal rotation. So that's a very clinical aspect of the diagnosis. And I And I just question, like, how is she able to understand what exactly is happening to her with such a clinical diagnosis? And then how can she be helped better to help her understand so she can also learn how to get better from this and get
Mm.
well?
I've been saying that word for 10 years and
Those are just some of the things that
I've been saying that word for 10 years and I still struggle with it sometimes. You need to kind of have a glass of water before you say it. It's a difficult word, and you're
Mhm,
100% right. Unless Mrs. Tiller is a health professional or speaks
yeah.
Latin, she's probably not going to be able to put that together.
Mhm.
And
We have Wendy also who wants to participate. Just
Wendy, if you could tell us again who you are and how you serve them, and provide us with your comment, please.
I'm a certified CHW in Hardy and DeSoto counties here in Florida. And we also work through collaboration and looking at the patient as a whole. Actual social determinants, as we know, affect the health of the individual. So in this case, I would like to add, they were concerned about her mental status being reduced. I have to think about the fact that she has kidney disorders, she has hypertension, she has so many things going on. She's been taken out of her familiar location, and she's placed somewhere without any help from anyone. It doesn't mention that her family was there or anything like that. It is actually expectable that she would have reduced mental status. There are a whole lot of comorbidities that go on with her, and before actually, just giving these few details of what she had when she was in the emergency department, there's probably a lot of things that they're not even looking at because they don't have her full medical history.
100%. And you hit something that I really want to delve into. So 100%, this patient is here with a hip fracture. The other context is secondary. It is secondary. And the thing about patients like Mrs. Tiller is when they experience that rapid change, like you just described, that disorienting rapid change, it has an immense impact on their mental status. And there's a condition we call sundowning, when the patient is in the hospital post admission and starts to have this extreme confusion and agitation. I cannot tell you how many times I have seen this, and the patient has been prescribed psychiatric medications because of that, because of the agitation was so severe, they were a risk to themselves or others in the hospital. It is astoundingly common all over the country, far more common than you might think. It's a reality of this intense change for the patient and the isolation that comes from hospitalization. And it is not managed the way, it is not an easy thing to manage, and there are a number of severe risks to patients. And that mental status change that becomes sundowning and becomes confusion and agitation, it often sometimes leads to post-admission psychiatric medications or new diagnoses of psychiatric conditions that become chronic conditions and predispose the patient to further risks of falls, of medical emergencies, and so forth. And the thing that starts that is the fall. It just starts with a carpet, with a a bathtub in Mrs. Tiller's case, a fall, ends up with a hospital admission, ends up with a psychiatric medication, ends up with confusion, agitation, additional falls in the hospital. I can't tell you how often that happens too. A patient gets a surgery like this, and they're in the hospital, they get up due to agitation and they fall in their recently fixed hip. I've seen that at least a dozen times. As you can imagine, for a patient like Mrs. Tiller, that does not bode well for her long-term prospects. That puts her at extreme risk of chronic disease and what we call exacerbations and what we call the precipitous decline, in which patients, older adults, experience an injury, and because of that and the consequences of that, experience a rapid decline in their health, in their well-being and independence over 6 months, and the morbidity for patients with hip fractures in this age is astounding. It's astoundingly high. It's very it emphasizes the importance of that prevention aspect, and keeping in the forefront of your mind that this is a real risk should form how you are talking to your patients and how you are assessing their condition every day. Fide, did we have a comment?
Yes, Wendy also mentioned her medication is not going to be managed in the same way either, and she should not be living in a home with a bathtub.
Oh, 100%, 100%. And I will say, a consistent issue with patients at this age is making sure that their home is disability accessible. That disability accessibility is not just about having access; it's about having safe access. Patients will push themselves in their environment to do what they need to do. Their independence is very important to them. And they will take risks, as we all do. And those risks can be removed with appropriate management. So that patient can live independently and safely at the same time. And that sounds like a lot of fun to me, Fide. Independence and safety. That's what we want for our older adult patients, and they can live their best lives. I will say that some of the happiest people I know are 85 and above. Allow them to continue to experience that happiness safely and to have that independence. It really brings so much joy to people's lives. So I'll open up again because we still got a number of important issues here. What is coming to the forefront of our mind when we think of Mrs. Tiller and we look at these new details?
Something comes to mind. Hopefully the emergency room well, she's admitted at this point. Obviously, she had the surgery, so she's probably admitted. So hopefully they can put all the different services in place, because it doesn't look like she really has a lot of support. So they can start with, if they are going to discharge her to a rehab facility so she can get her strength and PT, but they can even discharge her home with services and make sure that she has PT, OT, make sure that she has a home health aide. And then after the home health aide, they're usually there for a limited time, right? It could be, I don't know, 10 visits, what have you, 20 visits, and then maybe look into getting her long-term support services, which if she has Medicaid, it would cover a personal care attendant, someone that she can have that will, go in the home and help her with everything she needs, whether it's food shopping, light housekeeping, meal prep, almost kind of the same idea as what a home health aide would do, and a little bit obviously more than CHWs. They're really there, more of a teaching and helping to connect the patient, as opposed to there to, clean up the house and do different things. I don't know, that would be my suggestion.
I think you bring up a really important point, Benvinda. It makes me think of perspective. We have this situation now, whether we like it or not. We need to set Mrs. Tiller up for maximum results. We want her to do as well as possible from this, so that horror story of the precipitous decline just remains in the books for her. It doesn't become her reality. And the thing that I heard when you went through those resources is it emphasized to me the importance of that of the social worker in the inpatient setting and that discharge planning. And I can remember the basket of things that I would prescribe when I was in training for patients like this: the PT, OT, the outpatient services would be arranged by the social worker. So I would put the things that require a license and a signature. The rubber hit the road with the social worker, and so you mentioned a number of things that you would give for this patient, and I think they're very comprehensive, and it adds context for me, because I can see how that infrastructure is going to affect her chronic disease states and her risk of injury. When I'm thinking about some of the services you mentioned, I think of how quick Mrs. Tiller is going to get back to independence, how quick her recovery is going to be, and how long she's going to need to be at rehab. And the other thing I'm thinking, which based on your services, is exactly married to the risk that she's going to be experiencing, is what's going to happen when she goes home again. She's back at home, and she should not be facing the same risks she did to get her here. Something needs to be done in that outpatient planning, that discharge planning, and then that outpatient planning is what I, as a physician, I'm going to need to see, and what folks like you are orchestrating on the ground. So it's interesting. Earlier, you mentioned a bridge, and I've heard other CHWs mention infrastructure when they're discussing what they do. And what I'll say is that makes a lot of sense. It's exactly what it is when you think about it. So it is infrastructure. So thank you for that. And I'll say, Fide, is this your way of pushing me forward?
Yes, but we also have Rebecca. She has her hand raised.
Rebecca, if you could remind us who you are and who you serve and how you serve them.
I am a certified CHW for Heartland Rural Health Network and the Florida CHW Coalition in rural Florida. The only thing I will really add, I mean, we've all been talking about CHWs and we've pretty much covered the basics, is that while the first thing we would do, hopefully, is the primary care physician would notify us. Wendy and I have spent so much time in our hospital emergency rooms that we're just walking in at this point with our clients. And we have, that being said, we're in rural Florida. Our hospitals are 30 to 45 minutes away from where most of our clients are. So, you know, if God willing and the creek don't rise is a literal thing, because if that river goes up, it takes us a lot longer to get to the hospital. And it has happened to us before as well. But hopefully we've already been notified, knowing that our client stays at home alone. We've had 2 weeks with her, so hopefully we know more about her, that when we get to the hospital, we can be, again, that bridge between her family, and what's going on in the hospital, and the primary care physician. Because keeping our primary care physician up to date seems to help a lot more than waiting for him to get the report from the emergency room. But while this is all going on and coordinating everything for her, I would be doing like a 3-prong approach while she's in the hospital, while she goes into rehab. Am I going to go to her housing and see if we can get her bathroom changed to something more appropriate for her? They have funds. We just need to apply for them. Am I looking for an assisted living facility? Am I talking to her family? Is her moving in with them an option, even if it's just short term while she gets on her feet? I know that I've already picked out my assisted living facility and nursing home because I do not want to live with my daughter. I know this. So, you know, just these things, I would be looking at 3 or 4 different avenues and working on them all simultaneously so that once she's out of the hospital, there's something. She's not getting out of the hospital and being put in the same situation.
Mm. Yeah, so you know, you said a lot there, Rebecca, and there's a couple of things I want to follow up with you about. One, you mentioned that you guys are at the hospital ER a lot, and I've seen CHWs in the ER. I have a picture of why they're there, but I want to know more. Why do you post over there? And what's the strategy when you how are you seeing patients there, and why are you seeing patients there?
So a lot of times, sometimes in Wendy's case, she is the actual emergency contact for some of our clients because they have no one else.
Mhm.
We already know their medical history. We can walk in there and have a conversation with the doctor. We can coordinate with the primary care. Other times, my last trip to the emergency room, it was a call from my client's daughter. And in this case, this woman has run the orange groves her entire life down here, and she raised her daughters to be bulldogs just like her. So that wasn't a hard case, except when we had her neurologist that wanted to send her home a day and a half after her stroke in the middle of a hurricane.
Oh wow.
That's
So
awful.
coordination of care in this case was
Mhm.
sending boys from the Boy Scout troop to her home to
Oh
ride out the
my.
storm for her in her home, and arguing with this neurologist and being able to literally just tell her doctor or tell her daughters if I couldn't get to them and something came up over the phone. This is exactly who you need to talk to. This
Mm.
is exactly what you need to say. Do not deviate from this plan. You tell them exactly this. And she ended up staying in the hospital for like a week and a half. And we got her into a rehab facility because he did not want to send her to a rehab facility either. Now,
Oh,
all points for this particular client, she had health insurance. She didn't have any other social determinants of health except for her age, but she lived her alone. What, how are you going to go home alone after having a stroke?
can I ask a quick question? I'm sorry.
Please,
I
please.
want to
Yeah.
ask Rebecca a question. So Rebecca, as a CHW, who refers the patients to you? Do you work in the doctor's office for the doctors or the provider offices, or are you part of like a social service agency?
Our
Like,
referrals come from the hospitals, the clinics, social service organizations.
mm-hmm,
Um, a lot of our referrals come from former clients that you need to talk to Rebecca or you need to talk to Wendy. They can help you out.
mm-hmm,
So because we are so small, our CHW organization consists of
mm-hmm.
3 CHWs, and we cover 2 rural counties completely and partially on 2 other rural counties.
Okay.
So we get our referrals from everybody, but our local HRSA clinic uh,
Mm-hmm,
has a very one-on-one kind of deal with all 3 of us. Uh,
mm-hmm,
Wendy talks to the doctor a lot, and I'm
mm-hmm,
usually in clinic at least once a month, helping their navigators, and all we're doing is going
mm-hmm,
case by case.
mm-hmm,
Boom, boom,
mm-hmm,
boom. We'll spend a whole day just going through a case together.
mm-hmm.
Mm.
Because I was just thinking, um, see, usually most hospitals here, and I know I'm in Massachusetts, so our model of care is a lot different. But it seemed like everything was put on you, Rebecca. You're looking at assisted living, you're looking at these services for, so imagine how it would have been helpful too if the primary care doctor in Mrs. Tiller's case had maybe a social worker in the office. I know here in this state, any provider, any doctor's office that takes patients that have, say, Medicaid, has to have a social worker in the office working with the patients, because a lot of them, like you mentioned, have a lot of social determinants of health needs, right? So imagine how helpful that would have been to you, that the emergency room or the facility, the doctors in the facility would have called the primary care doctor and said, she needs VNA, she needs this. And then they would have in turn maybe had the social worker helping with some of these resources and referrals. And then you, of course, you're the direct contact because you're the one going to the patient's home, but maybe a little bit more, oh, I can't articulate it the way I want, but maybe a little bit more help for you guys too, as a CHW, to have maybe someone in these doctors' offices that can assess some of these patients' needs. So that way you guys are working on certain tasks that you're good at, that you can help the patient get and so forth, and maybe have someone else that's checking with housing or with Meals on Wheels, for instance, if she didn't have these things in place. But that way, I don't know, that way
Rebecca, I know, has a good answer for
patients
you.
could get more help.
Because she has Rebecca, I don't want to give your answer for you, but I find this is a fascinating conversation because CHWs in different parts of the country do completely different jobs, sometimes town to town. You are users of infrastructure, but also creators of infrastructure. And when I hear Benvinda and I hear Rebecca, I hear people with similar perspectives of how patients need to be served, leveraging their resources as creatively as they can, which is so interesting to hear. But I know, Rebecca, you have a specific system of working with your colleague Wendy that you've mentioned in the past. So I think I think if you can provide some details that might be helpful to everyone here. Do you mind?
Yeah, not a problem. So while other places use a CHW as a bridge, we're more like a mosaic. You have all the little tiles of healthcare, your health insurance, your primary care, your specialists, your emergency room, labs, the list goes on and on. And they're all these little different tiles. And we as CHWs in rural Florida, we're the grout or the glue or whatever we want to call it, filling in all those little gaps. Unfortunately, and we have seen it where there's CHWs, even here in Florida, we call them the city ones, that they have a lot more resources.
That's me then. I'm the
Their
city.
hospitals have more resources. Their hospital has more everything, more social services. They have stroke coordinators. They have all of these things.
Yeah.
And our rural hospitals, we just don't have it. We've got one rural hospital that has a team of 3 social workers. That hospital serves close to 40 to 50,000 people.
Wow.
One hospital, and it's a small ER. Another hospital, which is our certified stroke hospital, is the only certified stroke hospital in like 6 counties.
Wow.
So they're serving 6 counties. One of the counties they serve doesn't even have a grocery store. So when you look at, we're talking about mass volume to what is available. And so we serve the people that we can, and we just kind of try to fill in the gaps. A lot of times it is literally the people or the social worker or whoever, they don't know what they don't know.
Right.
I don't know what I don't know, but I'm going to find out. And I have that ability and I have more freedoms than someone stuck in a hospital
Mhm.
or someone that is limited by their agency. And I have some limits too. I just figure out how to work around them.
Yeah. And I think that's the big difference, right? Between, like you said, you work in a rural community as opposed to I work in the city. You know, we do have patients that live, you know, in the suburbs, in the countryside, but for the most part, all the hospitals, right? All the hospitals have even in the emergency room, they have a CHW, they have a social worker, and they have, did I mention, and care coordinators or navigators. So right when the patients are in the hospital before, or even the emergency room, I should say, before they get discharged, we're already notified. You know, we're the pay. I work for the payer more or less. I work for a health plan. We manage folks on Mass Health, which is Medicaid in most parts, right? And so it's, you know, it's daunting to see the social determinants of health that folks in rural communities go
Mhm.
through, right? Because like you said, the hospitals are so far away, there's limited resources. And so yeah, I see such a huge difference. But thank you for all the work you do. I mean, it's so important, all the work everyone here is doing.
Well, I'd say thank you both, and I'll add one more thing. You two should talk because I know for a fact that Rebecca does some side work with the CHW coalition, and you could have many other conversations that might help you both. And I'd love to encapsulate things for a moment because I really deeply appreciated this conversation about Mrs. Tiller and the services she would be providing, the perspective of the folks, the CHWs that are the rubber hitting the road, literally, is really profound to me because when I heard from Benvinda and then I heard from Rebecca, I heard from two people that are in people who are in opposite parts of the country, and as different as they are in different countries, and the thing that I found very interesting is you're both able to assess the social determinants of health uh, in those patients, even though they are in different areas, and that's the strength of your training and experience as CHWs. But I also see that depending on where Mrs. Tiller is, if she's in Waltham or if she's in Ocala County, there is a completely different infrastructure that she is touching. It is completely different. And in each case, whether the grout or the bridge, the CHW is what connects it. And when I think of what you all do, when I hear what you talk, what I hear is a CHW is someone who understands that infrastructure. They understand what is available and how to use it. The health system is your toolbox. And what I appreciate is that you can see that in each other as well. So thank you so much for that addition to our conversation. I'll ask that we go to the next slide, please. We're gonna go to the first X-ray. The first X-ray. I really want you guys to see these things. When you see a patient, an older adult, I want you to think of these X-rays. They're in what I see in my head when I look at an older adult, because I know what these things look like, and it makes it very real. And there are a couple of different types of hip fractures, three to be exact, three main types. I'm going to briefly go through them because it's clinically important information. The intracapsular fracture is what, if you think of the femur and the ball that goes into the hip, that is a very sensitive area of the bone. It has a lot of blood vessels, and it is very difficult to get that to heal in an older adult. That's one type. And let's go to the next one. Here's another, like you can see kind of more close up here. You can see the break, what it looks like, and sort of the shifting of the bone. in these fractures, there tends not to be internal rotation. Next slide, please. And here's what Mrs. Tiller had. And Jamoke, I'm going to ask you to please come forward because we had a great conversation with this, this earlier. When you think of this intratrochanteric fracture and some of the physiology and nutritional stuff that we've been discussing in our conversations lately, what are the things that come to mind for you when you think of Mrs. Tiller, if this were her injury?
Well, with Mrs. Tiller's medical background, we know that she has osteoporosis. She lacks a lot of vitamins and nutrients in her diet. So things that would support bone health, like vitamin C, vitamin D. The fact that this is the type of fracture that she has, you can see that it looks like it's shattered, or I'm zooming in. Where it's shattered, it's very sharp and brittle, and that's indicative of her medical state.
Oh yeah. Can you imagine how it feels? So you're zooming in on these shards here, and that's not artifacts. You're correct. That's the shards of the bone. Can you imagine how that feels going against your body and your muscles? And keep in mind the femoral artery and the great saphenous vein are there, and the hip plexus is where all of the nerves that go to your lower limbs, your genital, and your lower digestive tract comes from. So it's valuable real estate. You mentioned some nutritional things though, and you mentioned that this bone seems really brittle. Do you have any more thoughts about that?
I know osteoporosis is the weakening of the bone with small pore-like holes in the bone. And with vitamin C is the production of collagen, and as we age, that slows. So at her age,
I gotta stop you, Jamoke, because I love this part. Tell me, 'cause this is fascinating. That you mentioned collagen in the bone.
Mhm.
Do you know what collagen like? Tell why is that important? Why are we talking about collagen?
Collagen is the elasticity of our muscles and our joints, our bones, and all of that. And without vitamin C, it cannot be produced. And
Okay, so if Mrs. Tiller is vitamin C deficient for 3 years, how do you think that's going to affect her bones?
it will make them brittle. And her being a fall risk does not help.
100%. When I reflect on injury, and look, if we can go to the next slide, please, I'll reflect a little less. We've just got a moment. Here's what the repair looks like, and the repair is going to be different for each bone. But you can see the trochanter here. You can see the hip and the pelvis. You can see like that artifact near the stomach. That's actually the gas and the colon and so forth. You can see the muscle is the light stuff around the bone, and the very bright stuff is the metal from the hip fixation. There are two main
Wow.
bolts here. They connect. It's opaque, so you can see where the bolts connect, and you can see just how significant this intervention is. These things can be big, and if you can imagine what the recovery is. Also, keep in mind that these patients often fall right after they've had an injury. They need
Wow.
rehab, they need people at home helping them. And I know our CHWs have mentioned this, but these bolts will pop right out. And that hip will break in the same area. I've seen it if that
Wow.
patient doesn't get the appropriate support. So, not to scare everyone, but it would make me really happy is when you see your next Mrs. Tiller, think of what can possibly happen to them. Because I know I haven't, I know that when I see my older adults, each time I see them, I get to know them a little better, get to know more about their life and their challenges. And hip fractures are one of those injuries that have impacted me the most. And they're the ones that are at the forefront of my mind when I'm seeing my patients. I hope they are at the forefront of your mind too. And think of Mrs. Tiller and thank you guys so much for the service to your communities and and so forth. Fide, I'm going to mute myself. It's you.
Thank you, everybody. Thank you, Kevin.
Thank you.
You're welcome, and we really appreciated the conversation that you guys were having also. But thank you. Please also complete our post-evaluation survey, which will pop up on your screen right after the session. Again, your feedback is always very helpful to us. And then also as a reminder that the sessions will be posted on our website soon. And you can access them at nchph.org. And our final session will be taking place next week on the same day, at the same time. And that is all for today. Unless you have any
Thank
questions.
you. No, I would like for Rebecca and Wendy to connect with me. I added my email address. Maybe we can share resources and so forth.
Excellent. Yeah.
Okay, thank you, everyone.
Thank you. So me and no, Dr. Kevin Lombard is muted.
I'm sorry, guys. I'm sorry. So the session is over, but I'm staying on for a minute here.
Yeah. I'm gonna
you guys should. Are we recording off now, Fide?
Yeah, I'm gonna turn it off right now. For anybody else who doesn't want to stay, you guys are more than welcome to go back. But we're gonna just have like a brief conversation. Goodbye, Benvinda. All right, let me stop the recording.